Hi, thank you for viewing my fall referral application pitch deck. This has been created by myself, Will Whitmer, Talia Marshall, and Cassie Hill, all from Dalhousie University. So to give a little background on why we feel this is an important topic, falls are a major contributing factor to the hospitalization of elderlies. If we look at why people get admitted as you grow older, it's more and more because of a fall that has caused you to be admitted. However, not all falls are serious, and often people who have only minor injuries are transported to the emergency departments due to lack of community resources to help them with these falls, such as social services. However, if an elderly patient is transported to the hospital, nothing is done to address their home environment, which caused the fall, if that's messy hallways or something they tripped over, and they're likely to be discharged home and potentially fall again. Looking at the existing research that has been done into this topic, we can see through different reports, the one that I drew from was created in Nova Scotia, was most falls happen in patients' homes. They looked over a 4-year period at the amount that elderly people had falls, and 65% of the time it was located in their house, with nearly all of them being preventable. As well, most of the times when someone gets admitted to a healthcare facility, either hospital or long-term care facility, it was because of a fall. What I get out of this is if we make a patient's home safer, we improve their quality of life as they aren't being removed from their home because of injury, and we're also reducing the impact on the local healthcare system as people who are having medical emergencies aren't being brought to the hospital unnecessarily. So some programs already exist that attempt to do this. For example, if we look at community paramedicine, which is when an alternate pathway has been developed, which every time an ambulance or a paramedic goes to a patient residence, they don't necessarily get transported to an emergency department. Such as in Nova Scotia, there is already a fall referral program where paramedics are allowed to make referrals to local fall clinics instead of transporting them to a hospital 100% of the time. These types of community programs and referrals help reduce strain on the local emergency departments as it's reducing the amount of patients that arrive to emergency departments, and it also improves patient outcomes because patients get more specialized and appropriate care rather than a blanket statement, you're going to emergency department. So my solution is taking this community paramedicine referral idea a step further. First of all, from existing literature, we know that clinical decision support systems are proven to improve referral rates compared to traditional methods, and they are more effective when they're streamlined into healthcare workers' workflow. So what I am proposing is to create a streamlined application that healthcare workers, specifically paramedics, can use to increase community referral rates to local fall clinics and make that a lot more effective than it already is. And in addition to that, we can also create an application that the general public can use that highlights the risk factors of falls using the same knowledge base that we would use to create the paramedic version of the application, but not include any of the referral functionality of the application. The first step in creating any CDSS is finding an appropriate knowledge base. And here's an example of a knowledge base that would be appropriate for Nova Scotia, which is a documentation that is attempting to prevent falls in elderly Nova Scotians. And this can change from jurisdiction to jurisdiction. All we really need is a document that provides a list of risk factors that result in elderlies having falls. So when we look at how the healthcare application would work, the paramedic would conduct their call as usual. At the point of the referral, the patient would open up the referral application, the CDSS, at which point the referral application would automatically mine their electronic medical record for the pre-existing data that has already been inputted and auto-populate the referral to minimize the amount of charting or duplicate charting that happens. Then the paramedic will fill out any unanswered or any unfilled part of the application, and will be automatically sent to the appropriate fall referral facility. And this message that is being sent to the fall referral facility would likely be coded in HL7v2, but whatever standard is being used by the local health authority could be adapted to be used by this application. And this application would be considered a clinical decision support system because it will ensure all mandatory fields were being filled, and it will generate a referral that will be sent to the appropriate healthcare facility. When we examine how the public application would work, the same list of risk factors that is present on the paramedic application would be present on the public application, but this would have no other function. It will be just something you could download on your cell phone, open up, and it will just provide you a list of things to assess your health for to see if there is any risk factors for you having falls. For example, do you have enough handrails on your stairwell? And we'll look at a few examples of these later on. So here we can see what the apps would look like once we first open up. So under Fall Referral Program, this will be the healthcare provider version, and you can see a lot of detailed information is needed so a proper referral can be done. And the red stars or asterisks beside each of the categories mean that it is mandatory for this to be populated before the referral is sent. On the other side, we see at-home risk assessment, and this just gives a little blurb about why these things are important to check for, but there is no mandatory. It's just something that a family member could fill in if they need to, if they want to keep it for the personal health records. Then we have the risk factors that will be present on both factors. So we got this from our knowledge base. That was the strategic framework that we saw earlier on. And it just has a tick box where you can say if these are present or if these are not present. For a paramedic, they would fill out if these are present, and then they would send it off to the local fall clinic, and they will be able to see how many risk factors there are involved with this patient. And they, since the phone number was included in the header, they will be able to make contact and prepare an assessment, whereas a family member or a patient themselves could just go through this on the general public application and just see how many risk factors are present in their household that would indicate a fall. And for example, if a family member noticed there's many risk factors that will cause the patient to have a fall, they could talk to their general practitioner or another healthcare worker to try solving these or making the home safe for themselves before a patient has a fall. And this is where this program really has a dual-headed approach where you have the healthcare provider to, once the patient has a fall, help them prevent a future fall instead of just transporting them to a hospital. And also you have family members that can preemptively download this app and see how many risk factors are present in their house and try minimizing them so they don't have a fall and take a preventative approach. So I mentioned before that health applications need to be streamlined for referrals to be effective or to make referrals more likely to occur. So this is an example how a referral for a paramedic would happen without an application, whereas you have the paramedic starting in the bottom left corner. They just come to the point where they're going to want to refer a patient to a program. They will contact their medical oversight physician. They would ensure the medical oversight physician would have a conversation with the paramedic, make sure all the assessments are completed, and either approve or deny the referral. Then the consultation ends, leaving the paramedic to finish the charting and send a copy of their chart to the fall clinic, however that occurs. Where we see here is there is a big jump where a paramedic's flow has to go through a second person. There has to be a phone call or a patch over the radio that occurs for this process to happen. So when we look at how paramedics would do the referral with the application present, it's much more streamlined. The paramedics, instead of consulting another person, they would just open up the app. The app would ensure everything is completed, and then once the app is finished, it would send the refer off automatically, and then the paramedic would just finish their paperwork. It's just much more streamlined for the paramedic, and makes it much more appealing for them to actually do the referral. So when we look at the key differentials, we'll see that this is a much more streamlined process, as I covered before. It would support both public and healthcare providers having a dual-headed approach. And also the pros changes would be automate the referral, as it is done as we would have it coded properly by international standards, and it makes a much more personalized approach, as you could individually pick which risk factors are present and which are not present. And as this would be coded properly, there will be just some semantic interoperability as we use the HL7 V2 standards. So this is an example of the V2 standards, whereas if you sent this to another healthcare provider that's using the V2 standard, they would understand what each one of these messages would mean. And this is just an example of the back end, how we would code the application on the healthcare provider side. So when we look at measurable organizational values, the desired area of impact would have the social detrimental impact of improving the quality of life of many elderly Canadians, while providing peace of mind to family members of at-risk populations such as seniors. The desired area of impact the project would help equip providers along with general population with the tools that would make their home environment safer by reducing preventable transports to the hospitals and injuries by way of the application they and their family members can access remotely. The metric is when implementing into a particular jurisdiction, there is an increase in referrals to the local fall clinics, and in effect, the volume of transports of elderly falls with no sustained injuries should decrease. And for timeline, the development and implementation could easily be conducted within the first year of launch. Within the context of gig economy, the build out and launch of an efficient and short-term project like this would benefit not only stakeholders, institutions, but the patient population over the long term in personalized, digitalized, and handheld ways. And just looking at our critical path, how we think it will go, the critical path goes phase 1, phase 4, phase 5, and phase 6. Each of them are relatively short and within a reasonable time period. So we think this is an easily manageable, not too large of a plan. These are references, and thank you for listening to my project.